Welcome to The Explainer. Today we are tackling a topic that is, no joke, one of the most critical you'll face as a nurse: shock. This isn't just about memorizing facts from a textbook. Nope. This is about building that solid clinical judgment you need to act fast and act right when every single second is on the line. We're going to break it all down from what's happening at the cellular level all the way to what you're doing at the bedside. So why does this matter so much? Let's just start with a number. A really big one. Over 250,000. That's the number of people who die from sepsis every year, just in the US. And guess what? Sepsis is one of the biggest superhighways leading straight to shock. This isn't just a statistic, It's the reason why you have to be an expert on this. It's about saving lives. So here's our game plan for today. First, we're going to build a really strong foundation, what shock actually is. Then we'll get into the 4 different types. After that, we're shifting gears to your role, what to look for and what to do. We'll even load you up with some awesome memory tricks for your exams. And to wrap it all up, we'll drop you into a clinical scenario to put your new skills to the test. All right, let's get right to the heart of it. Before we can even talk about how to fix shock, we got to ask the big question. What is actually physically happening inside the body when it goes into this crisis mode? What's the domino effect that puts everything on the line? Okay, if you remember one thing, remember this. Shock is a crisis of perfusion. That's it. Think of the body's circulatory system like a delivery service. Its most important package is oxygen. Well, in shock, that delivery service fails. The oxygen isn't getting to the tissues and cells. And without oxygen, cells can't make energy. They start to shut down. And that kicks off a catastrophic chain reaction that leads straight to organ failure. Now, it's so important to get this. Shock isn't like flipping a light switch. It's more like a very fast, very slippery slope. It starts out silently in that initial stage where all the chaos is happening at the cellular level. Then the body's alarm bells go off. That's the compensatory stage. The body is fighting like crazy to keep things balanced. But it can't keep that fight up forever. If we don't fix the root cause, the body slides into the progressive stage. And that's when things start to fall apart, leading to that final refractory stage, which is the point of no return. See why catching it early is everything? Okay, so we've established that the endgame of shock is terrible perfusion. But how does the body get there? Well, it turns out there are 4 main roads to this disaster. Figuring out which road your patient is on is absolutely key to giving them the right life-saving care. This slide is gold. Seriously, these little analogies are going to be your best friend. Just think about it like this. In cardiogenic shock, the pump, the heart itself, is broken. In hypovolemic shock, the pool of blood is just too low. There's not enough fluid in the tank. Obstructive shock, that's like a pipe is blocked, maybe by a clot, stopping blood from getting through. And then you have distributive shock, where the pipes, your blood vessels, get way too wide and all the pressure is lost. Simple, right? Now let's just zoom in on distributive shock for a second, because it's kind of a big category. You've got 3 main culprits here. Neurogenic, maybe from a spinal cord injury where the vessels lose their tone. Septic, which is that massive out-of-control response to an infection. And anaphylactic, which is a severe allergic reaction. See the pattern? In all 3, the result is the same. Those pipes get dangerously wide and blood pressure just tanks. Okay, we've got the what and the why down. Now let's get to the how. How do you, the nurse at the bedside, spot this coming? This is where your clinical judgment really kicks in, with that crucial skill of recognizing cues. What are those signs that tell you your patient is in deep trouble? These are the classic signs, and you need to know the why behind them. The body is in panic mode trying to compensate. The heart beats faster, tachycardia, to try and move blood around. You start breathing faster, tachypnea, to pull in more oxygen, but it's not enough. The blood pressure drops, the kidneys aren't getting perfused, so urine output plummets, and the brain starts to suffer, which is why you see confusion or anxiety. Spotting this cluster of symptoms is a superpower. And the lab work? It tells a story. That rising lactic acid level, that's a direct signal from cells that are screaming they're being forced to work without oxygen. Your ABGs will show metabolic acidosis, which is clear evidence of all that cellular stress. Oh, and don't be surprised if you see a high blood glucose. That's just the body's stress response, dumping sugar into the system for a fight it's about to lose. Recognizing the signs is step 1. But what you do next, that is the absolute game changer. This is where judgment turns into action. So you've spotted it. Your patient is in shock. What are your first moves? Your absolute must-do right now priorities. This is a mantra. You need to tattoo this on your brain. When it's hypovolemic shock, you replace volume first. You can't squeeze the pipes with vasopressors if there's nothing in the pipes to squeeze. It's like trying to get water out of a hose by kinking it harder when the spigot is barely on. You have to fill the tank first, usually with something like normal saline. Okay, here's your rapid fire checklist. Boom. Step 1, airway and oxygen. Always. Get them on a non-breather mask, high-flow O2. Next, get good IV access. You need that lifeline for fluids and meds. You can also position them flat with their legs up to help venous return. And from this second forward, you are watching them like a hawk. Vitals, heart rhythm, urine output every hour, and always be thinking one step ahead. Be ready for intubation. Now let's talk about the big guns, the medications. You've got two major players. First, you have inotropes, like dobutamine. These are all about improving the squeeze of the heart. Then you have vasopressors, like norepinephrine. These are about squeezing the pipes to get that blood pressure up. Knowing which one to use and when totally depends on what kind of shock you're dealing with. But wait, there's more in your toolbox. For cardiogenic shock, you might actually use a vasodilator to make it easier for the failing heart to pump. For septic shock, you're on the clock. Get those antibiotics in within the hour. Anaphylaxis, you're reaching for antihistamines. This just proves that you can't have a one-size-fits-all approach. The treatment has to be targeted to the cause. Phew, we have covered a ton of ground. So now let's make sure all this information gets locked in, not just for your next exam, but for your entire career. We're going to go over some really helpful memory anchors and do a little NCLEX practice to make sure you've got this down cold. Okay, this is my favorite memory trick for shock. It's the 4 Ps. You ready? Cardiogenic is a pump problem. Hypovolemic is a pool problem. Distributive is a pipes problem, and obstructive is like a parked car blocking the road. See? Pump, pool, pipes, parked. It's super simple and super effective. All right, let's do a quick knowledge check NCLEX style. A nurse is assessing a client in shock. Which findings should the nurse expect? Select all that apply. I'll give you a second. Okay, got your answers? The correct ones are C, D, and E. You'd expect slowed cap refill, low blood pressure, and fast breathing. Urinary output goes down, not up, and the pulse would be weak and thready, not bounding. How'd you do? And last, you have to know about the 2 nightmare scenarios that can result from shock. First is MODS, multiple organ dysfunction syndrome. It's that tragic domino effect where one organ starts to fail, then another, then another. The other is DIC, or disseminated intravascular coagulation. This one is a cruel paradox. The body forms thousands of tiny clots everywhere, which uses up all its clotting factors, and then the patient starts bleeding from everywhere, uncontrollably. Okay, let's pull all this out of the theoretical world and put it right where it belongs, in a real clinical situation. Because knowing the information is one thing, but applying it when the pressure is on, that's what being a great nurse is all about. So picture this. You've got a 78-year-old patient, 2 days after surgery. You walk in and suddenly they've got a new fever, their BP is low, their heart is racing, and they've barely made any urine for the last couple of hours. As a nurse who knows how to recognize cues, those alarm bells in your head should be screaming. This is a classic picture of septic shock. So, what now? You've seen it, you've recognized the pattern. Based on everything we've talked about, your priorities, your interventions, the potential dangers, what is your very first move? What are you anticipating? This moment, this is where knowledge becomes action. And that, right there, is the heart of nursing.